Hello, Law and Mental Health Conference. Thank you so much. I'm really honored to be invited to be sharing some thoughts about alternatives to civil commitment. And I really want to thank my colleague Jason Renaud for all of his hard work making this conference possible and for inviting me. Who am I? I am a survivor of psychiatric violence. I was forced into treatment, civil commitment, against my will. I was put in restraints. I was in solitary confinement. I was traumatized by that experience. I continue to have trauma symptoms from that experience. And since then, I have become an activist and organizer with the psychiatric survivor movement, as well as going on to get a degree and becoming a counselor and a trainer and teacher around alternatives in the mental health system. I'm also currently a PhD candidate in psychiatric epidemiology at Maastricht University School of Mental Health and Neuroscience, doing my graduate work on medications and alternatives to medication. So I have a personal experience of the harm that can come from civil commitment, and I'm going to be presenting some of what I understand as the context of the question of alternatives to involuntary treatment, and some examples of the alternatives that are out there and available for us. And I just want to emphasize that the work that I'm presenting is research and evidence-based, so if you need any help with citations or backing things up from a research standpoint, please feel free to get in touch with me. My website is willhall.net. You can also check out my websites, madnessradio.net, and my book, which is a collection of more than 40 interviews called Outside Mental Health at outsidementalhealth.com. And that goes a bit more in depth into some of the things I'm going to be touching on today in my short presentation for you. And I'm also going to be on the live panel, I believe, so I'll get a chance to answer questions and be involved in discussion. So why are we looking for alternatives to civil commitment? And I want to be clear to begin with that I don't think anybody is making a case that everyone who has been involuntarily confined or involuntarily treated in the community, that everyone feels that they were harmed and everyone is against involuntary treatment. What we're making is an argument that says that the risks and the costs and the harms and the deprivations of liberty associated with involuntary commitment are so extreme and so severe that they really, to me, indicate that this is a complete moral failing, and that my position is abolition of civil commitment and involuntary treatment. And I take that as a very strong moral position, and I'll explain a little bit more about why I think it's important that we take that moral position. So the reality is that when we talk about involuntary commitment, civil commitment, forced treatment, it's a sanitized bureaucratic way of talking about state-sanctioned violence. What we're doing is we're using a medical justification to allow the state to agree that under certain circumstances, psychiatrists, doctors, nurses, staff, police, people involved in involuntary commitment can assault, kidnap, and confine people. And I'm not using those words lightly. That was my experience. The traumatic impact is no different from assault, kidnapping, and confinement. The deprivation of liberty and the seriousness of that means that we have to have a very high bar for why are we justifying this in the context of a medical diagnosis. And the reality is that these also the threat of civil commitment, the threat of forced treatment is also used. It's an additional insult, an additional injury. So even though we can talk about there are people who don't feel that they've been harmed, who endorse their own deprivation of liberty, there are clearly many people of which I am one, there's an international movement of people that are saying that this is violence and it's unnecessary. Now, the argument about is it unnecessary exactly hinges on the question of, are there alternatives? And the reality is that we do have many alternatives. There's an extensive research base. There's practical experiences internationally of alternatives being in place and being used right now. But without that moral imperative, without the abolitionist stance, where's the incentive structure? Where is the motivation to use alternatives and to fund alternatives and to develop the resources that are needed to make alternatives available when it appears and it seems that force and the old way of doing things is more readily available and more convenient for us? So the reality of people being harmed, we should also emphasize, is disproportionate to people of color. BIPOC people have much more of a likelihood of being victimized by forced treatment, of receiving inpatient forced hospitalization, inpatient forced psychiatric treatment, or outpatient through community treatment orders and assertive community treatment and outpatient commitment. So there's a disproportionate element here in terms of racism. There's also the impact is much higher on people who are facing poverty and who don't have the education or the social resources and social capital because of their vulnerability in the due process around civil commitment and their availability of other resources, which can often simply be a place to stay rather than being on the streets with their crisis. So some of the other reasons that ending involuntary commitment is really important is that the argument that was made for me why I was put in to the hospital was that, well, we have to protect you from suicide. Two things. Involuntary treatment itself, forced hospitalization itself, is a risk factor for suicide. There are a number of studies that have been done showing that the risk is higher among people who've received involuntary services. That time after discharge from the hospital is the most dangerous for suicide, I believe, because of the impacts, the traumatic impacts that forced hospitalization can have. The idea that you can do an assessment of suicide risk and then you can decide, well, this person, we're going to deprive their liberty, we're going to put them in restraints, we're going to inflict traumatic experiences on them in the hospital. Well, it's worth it because otherwise they would kill themselves. That is not what the research around suicide says. There was a study done by the U.S. Army that surveyed all the research assessment, the suicide assessment research literature. It is not possible to determine who is going to kill themselves and who is not going to kill themselves. And so the number of false positives is very high, and the impact of that forced treatment can dramatically undermine the trust and the relationship with clinicians. So the suicide prevention argument doesn't hold up, although that's the primary reason that involuntary hospitalization is used against people. The treatments associated with involuntary commitment are primarily medication. This is extremely controversial. First of all, there are a lot of people who just aren't helped. They will be sedated, they might be tranquilized by their medications, but in terms of actually gaining function or alleviation of their symptoms, significant number of people who are treated with antipsychotic medications or mood stabilizers, lithium, bipolar medications aren't helped. The adverse effects include death, organ failure, chronic disability, disfigurement, cognitive impairment, brain shrinkage is associated with the antipsychotics, the loss of personality. When I was on antipsychotics, I wasn't able to read and think creatively, have my ordinary familiar personality was taken from me. These are tranquilizers. And there is an idea that, well, we're treating a disease, and so we have this moral obligation as medical providers to treat a disease and not just let a disease be running rampant. But actually that's not the case. The medications are tranquilizers. They're used primarily for behavioral control. There's no evidence that there is some disease mechanism in psychosis, for example, that is corrected by antipsychotic medication. Also, by relying on medication treatments and medical diagnosis, we are medicalizing social problems. People are experiencing domestic violence, they're experiencing child abuse, they're experiencing poverty, they're experiencing racism, they're experiencing different kinds of oppression, social isolation, lack of connection, unemployment, the stresses of living in a capitalist, consumerized world. All that gets wrapped up and put aside because now we say the problem is inside the person's head. So from a medical standpoint, involuntary commitment usually, I would say always, violates the principle of least intrusive response. That least intrusive means voluntary. And we don't have voluntary available because we don't have the resources, we don't have the investment in those voluntary treatments. So we have to think beyond involuntary commitment because it violates the principle of least intrusive treatment. And there's actually a Supreme Court ruling in Alaska that supported this, and that Jim Gottstein argued before the Supreme Court, that was able to successfully argue that, look, medications aren't just a simple treatment for they have huge risks, and they're not the least intrusive, forcing someone onto medication. And so some kind of provision has to be made for people to get non-medication options. Another argument against involuntary commitment is that the due process associated is a complete farce. These are kangaroo courts. You go into court, there's no adequate representation for the patient, and essentially the judge, who is overworked, and there's tons of these commitment cases and conservatorship cases clogging the courts, they just go with what the psychiatrist says, and lack of insight and proof that you are ill and have no competency to determine for yourself comes down to whether you disagree with the psychiatrist or not. So it's a very neat, maddening Alice in Wonderland circular tautology of, well, if you disagree with the medications, it means that that's your disease speaking, and therefore you need the medications. And of course, if you have insight, then you would agree with the medications, but then you end up going along with the doctor who says you need the medication. So this is really a farce of any kind of judicial ethics or respect for the rights of the individual. It's unfortunately a symptom of our larger problem of our court system. And of course, if you have the resources available to get your own psychiatrist and your own representation, you're going to have a much better time to get a fair hearing in court. Importantly, we have to recognize that this is a human rights issue. The United Nations has passed the Convention on the Rights of People with Disabilities. The World Health Organization recently came out with a big report and determination. We need person-centered, voluntary, holistic care that recognizes the social context of the individual, but does not focus on the disease and disease treatments as being the be-all, end-all. That personal choice and the right to refuse medical treatment is an extremely respected, valued, protected right in a free society. So the alternatives that are there, very difficult. There are no incentives. Who is going to be pushing? There's not a profit incentive for alternatives. So we have to really treat this as a moral emergency. Then if you take an abolitionist stance, then you are forced into saying, okay, we've got to get these alternatives in place. It's unacceptable to just say, wouldn't it be nice to have alternatives? No, this is a moral evil that we're dealing with. So the bad news around civil commitment is that typically when someone ends up involuntarily hospitalized or involuntarily treated, it is the downstream effect of larger social forces. We see this with crime, we see this with homelessness. We need a commitment to the systemic origins, the systemic upstream causes that lead someone to be at that point of involuntary commitment. And that is very difficult to do, but unless we name it and we recognize it and we talk about it, if we normalize it, that is the change is never going to take place. So that's the bad news. Also, that the costs are externalized. You force someone to the hospital, the police drop someone off at the hospital for an eval, then the impact on society, on that person, the impact on liberty, the impact of that person's trust, all that is externalized. It's not in the equation of the insurance reimbursement and the normalization of it by standard procedures with law enforcement. So those are the bad news. That's the bad news. The biggest bad news is that there are social determinants of mental health crisis, that if we really want to not be in a situation where we're using this band-aid last minute downstream approach of involuntary commitment, we've got to go upstream and deal with the problems of a failing capitalist society based on growing inequality that's entrenching appalling homelessness, appalling poverty, entrenching trauma, destroying communities, undermining human connection. People just don't, they're working too much. There's no community resources, there's no family resources, there's no money for services. We're not going to deal with this problem until we deal with those upstream systemic causes. The good news is that there are lots and lots of alternatives, proven, research demonstrated, evidence-based alternatives. I'm just going to go down a list of them. And the key thing, if you have one thing that you come away with from this talk, mental health crises are about isolation and disempowerment. They're not about an infection in your brain or you're a crazy person. They're about a long history of isolation and disempowerment. All the effective solutions are about connection, relationship, empowerment. We know that to heal from trauma, you have to feel safe, that your choices will be respected, that you have control over your bodily boundaries. Trauma is so often the foundation of mental health crises. We know that poverty isolates and disempowers. So voluntary services build those relationships of trust, give the person back a sense of capacity, even if it's a little step at a time, even if it's a long journey to regaining that sense of connection, to regaining that sense of control. Another basic aspect of all these alternatives is early access, early connection. The downstream problems happen because of upstream neglect. And some of the alternatives I'm going to be speaking for do an excellent job of dealing with problems early. So I'm not talking about medicating people early. I'm not talking about giving people bipolar diagnosis because they have difficulties as a teenager based on family conflicts or poverty or trauma or adjusting to being queer in the world that doesn't support you being queer or being trans or dealing with racism or dealing with ancestral trauma and then just medicating that. I'm talking about responding to human needs early with connection, with community, with overcoming isolation, with helping the people to have a sense of control and connection and empowerment in their lives. Is that going to take some money, that prevention, that early involvement? Yes. But again, we know in a capitalist society that it's short-term turnaround. The long-term planning, long-term prevention is very hard. We have quick fixes, we have band-aids, we have treat the symptom, not the cause. But the reality is that if we invest the time, energy, support, resources early when people start to have difficulties and prevention before those difficulties arise, we will save money in the long term. Being on chronic disability payment is a huge cost, it's a huge opportunity cost and loss. I was on disability, I'm diagnosed with schizophrenia, I was on disability for 15 years. Looking back, if I had just had a few of these services in place, if I had just had a few supports, if the Social Security system was just reformed a little bit, it would have allowed me to transition off. I could have been with that disability check much less time, or not even at all if I just had some more effective bridges through alternatives. So let's go over some of some of these alternatives that you may have heard of, that you may not have heard of. The peer support movement is growing, and the significance is not just to save money because you're using paraprofessionals. I think peers should be paid much more than they're getting paid. But the point is that it's a connection. People can relate to someone who's been through it. Like, oh, you have a diagnosis of schizophrenia? You were able to get off of this chronic cycle. You were able to move out. How did you do it? Someone's going to tell you because they read about it in a book or in their class, or they went through it themselves. We know this from drug and alcohol and addiction treatment, that the AA model, there's problems with the AA model, but the basic idea of peer-to-peer and learning from each other is incredibly sound because, again, it builds that sense of empowerment. It builds that sense of connection. So peer support, peer specialists mean much, much more resources and funding and widespread prevalence. And so it's not just one peer specialist in your program because you've got a contract obligation, but you've got actually several who are working with your staff to change the whole culture to recovery-based, patient-centered, voluntary, respect, self-determination that the peer specialists understand because they work from that recovery model. Warm lines and hotlines when there's a crisis, warm lines just when you need support, because crises have buildups. Bipolar episodes, psychotic episodes don't just come as a lightning bolt from the sky. There are buildups, there's a history. We can catch that in the early stages if we get people access to warm lines, give people a place to go, give them someone to talk to. People need to have access to therapy and counseling, support groups, drop-in centers, community centers, because this reduces, these voluntary services reduce the reliance on this horrible, horrible moment when we're depriving someone of liberty and assaulting them and forcing them into treatment. We need skilled people responding to mental health crisis, not the police. The police are going to show up. There's fear, there's coercion, there's threat, there's danger, there's triggering, there's escalation. The police are not skilled. We shouldn't expect them to be because they're police, not counselors or healers. And that is going to escalate to a situation where they're going to rely on the drop-off and the involuntary treatment. Get the peer supporters in there. Get the people who've been there. Don't even involve the police at all. Services are going to be used more readily and earlier in the process, because who wants to have cops come to your home? If you could have community resources and community supporters coming, then they can divert the process away from the coercive, involuntary scenarios and often de-escalate just on site. Just help people connect them with some resources. So not responding with police. Wellness checks by police. Police should never be doing wellness checks. Forget it. Find other resources to do wellness checks. We know that with people who are called chronically homeless, they may be living out, it may be cold, there may be danger, but we know that they don't want to go into services because they've had bad experiences. Their stuff gets stolen, they might get sexually violated, they might have ended up in forced treatment, there might be fights and violence, there might be overcrowding. And so we know that with working with people like this, to build a relationship. Okay, you go back to the site where they have their camp and you build a relationship. And then we know the best homeless support and outreach, same principles of empowerment, choice, voluntary, connection, building a relationship. That also works with people with mental health problems. Even if they're in altered states, even if they are not communicating ordinarily, you can bring them a sandwich, you can sit with them, they will eventually start to get used to you being around, then maybe they start to open up and talking, and then you can maybe start to get them engaged with services. We need much, much more community outreach of skilled, experienced, especially peers. Don't have a lot of time. I'm just going to mention a few more of these because there are many. And I want to point out also a website, madinamerica.com. I'll talk about that. Advanced directives. Don't just assume that it's right for me to go in the hospital. If I sign a living will, an advance directive that says under no circumstances send me to the hospital, that's my medical choice. I'm doing it competently. I don't want forced treatment. I don't want forced drugging. Leave me alone. Figure out something else to do with me. Make those advance directives legally binding, just like they are in cases of severe illness or do not resuscitate kind of context. And you may say to yourself, well, we know what this person needs, but they've created an advance directive and that should be legally binding. That's their choice. A lot of us I would rather go to prison than go to a psychiatric hospital for a lot of different reasons. One, a prison has an expiration date and you get some semblance of due process. The hospital, you get angry, you start yelling, the psychiatrist decides, sorry, you're still here. Oh, you don't want meds? We're going to keep you for longer. So give me the choice of what to do with an advance directive. We need to recognize, as I was mentioning before, suicide assessments are not predictors of suicidal behavior, and to recognize that often the forced treatment, forced hospitalization is not safer. That person could become traumatized. The risk-benefit equation is extremely inaccurate. Often it's just the standard of care. The professionals are afraid of getting sued or getting their superiors. So, okay, we'll just put this person in the hospital based on a suicide assessment. We need to break through a lot of the stereotypes around so-called severe mental illness. Hearing voices, hey, it's a human variation. Psychiatry used to call homosexuality a deviance and a disease and a pathology that had to be treated, often with lobotomy, electroshock, forced drugging, forced hospitalization. Psychiatry pressured to not do that. We need to start pressuring psychiatry to also see these other human variations as an accepted part of human diversity. Just because you're hearing voices and need to talk back to them doesn't mean you need to be forced into a hospital. People with mental health diagnosis are not more dangerous. We should not be treated as a public health threat. When someone is suicidal, they're not threatening to hurt other people. How many times have the police responded to a suicidal situation as if they're responding to a terrorism situation? So when people do not want to take medication, let's give them places to go. There's a hospital alternative that was established in Norway. It's a medication-free hospital. These should be available to everyone in the United States. If you want to be in a hospital setting, but you don't want to take medications, that should be your choice. Let's have a special place for people to go if the staff can't handle that. And we need hospital alternatives. There are peer respites around the country. AFIA in Western Massachusetts is a wonderful example. There's also soteria houses, which are alternatives to hospitalization. People can go when they're in distress to a hearing voices group, or even a suicidal feelings support group, alternatives to suicide group. So these alternatives to people who are in distress are extremely important. When there are people who are going in and out of the hospital, we should recognize that it's talked about in some of the research and policy literature as the high flyers. They're going in and out of the emergency room. They're going in and out of the shelters. They're going in and out of the 911 calls. If you actually invest a lot of resources to wrap around that person with voluntary services and find out what they need, that will pay off later. And we saw this in Richmond, California, where violence was reduced by identifying people who are at risk for committing active violence, gun violence, especially around other people, towards other people, and then finding out who they are and providing them with special preventive services. There actually is a program in Sweden called the Healing Homes Program, where they took people who were chronically medicated in and out of the system, in and out of prisons, and they put them into foster care kinds of settings with families that are especially trained. The families also got support and therapy, lots of resources, lots of support. And through the normal process of being integrated into a farm family and expected to milk the cows and help with breakfast and do your chores, people who were seen as chronically paranoid, schizophrenic, mentally ill, needing large doses of medication, a lot of them would start to come out of that role because they're expected to be in a different role, and then they would start to move on with their lives. So I also think we need to realize that, and I hear this quite a bit, that, well, we need to force someone to the hospital because it's a better alternative than prison. Yeah, prison's a really rough experience, but again, systemic causes, systemic solutions. We need to start to think about reforming our prison system so that we're not looking at, well, okay, we're trying to protect someone from the prison system as a harm reduction approach. And finally, I want to say just very briefly about Britney Spears. If one of the most celebrated and talented and hardworking celebrities globally can completely have their rights deprived in plain sight over years by a family member who is clearly abusing that role and abusing the court system, our conservatorship system is completely broken. The conservator program, the conservator system is completely a fail, and we need to be completely overhauled, and we need to do it in the context of understanding that forcing people into treatment, which is often, conservatorship is often like the end of the line after repeated involuntary hospitalizations, that it's all a part of a misunderstanding of what people's needs are. So I've said a lot. Again, I want to say to professionals, what do you do? I mean, you're in a situation where there aren't alternatives, and the solutions are also addressing these systemic problems in capitalism and inequality and the horrible priorities of a consumerist society. What do you do? And I ask the professionals, please take a clear moral stance. Don't be on the side of assaults, kidnapping, and confinement. Take a clear moral stance that this is wrong, and then present the dilemma. It's wrong, and what are the other alternatives? Oh, the alternatives aren't available. Okay, what are we going to do here? I wish that there were more alternatives. I'm on your side. I really see that this is a terrible, broken system. What are we going to do here? Because we've got choice between bad option A, bad option B, bad option C, and we're in a harm reduction context. If professionals are honest about the immorality of what is happening, they will help to build trust. They will start to begin to rebuild the trust in the institutions that professionals are part of, because now patients just see this entire bureaucratic institutional edifice as endorsing this moral evil. So separate that out. Start to make your voice heard. Make a clear stance that you want alternatives. You don't want to be in a position of putting people in the hospital or doing anything against anyone's will, depriving them of their liberties, throwing them to a kangaroo court system that does not respect the fundamental rights of due process, and that you don't endorse this second-class citizenship, that we all deserve to have equal rights in a society, and telling people that just because you have a psychiatric diagnosis, now you lost your rights, it's just on that basis alone, is a moral evil and should be abolished. So take that position, educate yourself, go to websites like madinamerica.com, go to organizations like NARPA, the National Association of Rights Protection and Advocacy, familiarize yourself with the Committee for the Convention for the Rights of People with Disabilities of the United Nations, the World Health Organization, the international efforts around involuntary commitment, and join this movement. There's a lot of professionals who are in exactly the same kinds of career positions that you are, who are part of this active conversation, this active dialogue, this active advocacy and pressure to make these changes happen. Because yes, there are systemic changes that need to happen, but those changes aren't going to happen if we don't start demanding them. So thank you very much, and I look forward to our live Q&A dialogue, and please feel free to contact me at willhall.net. Thank you very much.